Welcome to Cancer Speak, the official podcast of Cancer, a journal of the American Cancer Society. Cancer Speak is here to bring the best of science to the broadest of the audience, offering the latest research, real-life stories, and expert perspectives from the field of oncology. Today's episode marks the end of our four-part series featuring a conversation between members of the American Cancer Society National Navigation Roundtable to discuss patient navigation and cancer care. Topics explored in today's conversation are also covered in a free-to-read supplement to Cancer entitled A Decade Later, The State of Patient Navigation in Cancer. All 13 articles from the supplement are available to read at canceronlinejournal.com.
I guess expanding further on, thinking about the description of different classes of navigators in terms of the types of delivery. Angela, I'm going to shoot this one to you. In terms of really thinking about the work of the NNRT, the evidence-based task group, they really did a little bit of work talking about subclassifications of navigators, class 1 and 3 subgroups, thinking about them as clinical, focused more on treatment and survivorship, end of life care, work in programs that were operationally funded. In contrast, there's a group 2, as they were defined, a subgroup that tend to be non-clinical, focused on outreach, education, screening, and early detection, which had proven to reduce disparities, but were largely grant supported. Why should organization leadership reevaluate and provide better operational support to that class 2 subgroup? Again, that group who's more non-clinical, focused on outreach, if the goal is to reduce cancer disparities. And so I guess, kind of thinking about this round out and that work of the evidence-based task group, Angela, what's your thought?
Yes, excellent. Yeah, and when I think about reducing health disparities, and we think about reducing health disparities, you have to think about how can we prevent cancer? If we can't prevent cancer, how can we detect cancer in the early stages? So how do we increase the the screening so we can detect people in the early stages so that they will have more treatment options, they'll have less expensive care, they'll have um, um, uh, more, well, less harsh treatments, and we know we're going to have better outcomes. And so, if we're looking at reducing health disparities, I think organizations need to put a little bit more focus, especially with some guaranteed operational funds to make sure that we're putting more health out in the community. Um, Too many times we expect patients to come to our huge facilities and be overwhelmed, but we need to really reach out to the communities, especially in these populations where we know we have a lot of mistrust issues. We have a lot of individuals that have difficulty getting access to care. So, it's almost like, prevention is not given enough um, credit, as well as is not getting enough emphasis, because it's sometimes hard to measure prevention. A lot of times you look and say, okay, if we have a person that's diagnosed in the early stages, how much is that going to cost us compared to someone that's diagnosed in the later stages? How much money we're going to put in care and resources we're going to put in an individual that is in a stage 3 or stage 4 diagnosis? We know that there's going to be less options available for that person. The treatment is going to be much more expensive, and we know we're going to have poor outcomes. And so I think we need to do a shift. We're talking about decreasing health disparities. We need to make sure we do a shift amongst this class 2 population that's out there doing outreach, out there educating people. I think a lot of times we have things for granted that people know when they should get screened for certain cancers. And, working out in the community, you'll be amazed at people that don't know, like colorectal cancer screening, it was reduced from 50 to 45. We still trying to educate some of the providers and have people change some of their systems and their policies to match up with the new guidance. And so being able to educate people that way they can advocate for themselves to get the proper screening. But we definitely need to make sure that we provide funding so we can be more ahead of the curve to try to reduce these health disparities.
Awesome. And I think, Angelo, Electra, Sharon, others have brought up, even in this setting, the roles and complementing work, as well as showing that outcome data. I know data's been stressed by both Elizabeth as well as Linda. I think what you're talking about is really that if we really stress and really talk about, even for these people who are doing sometimes this kind of non-clinical focused outreach, sometimes it's been a nice to have, but showing that value as it relates with those sort of compelling components can make all the difference for sustaining. So I really appreciate those comments, especially as we're really thinking about people who, as you mentioned, don't oftentimes also access sort of the traditional settings. I mean, there might be outreach and in that community, which I know you've done a lot of work, but I think it really is about that complementing of both, and really that also the people that have oftenly, the non-clinical focus, but have that education and outreach and that screening early detection that you mentioned, there's huge value in that as we think about downstream. I'm going to shift gears a little bit as we're getting ready to close out, because I do want to think, and I know Sharon Gentry as well as Patricia Valverde, several of us worked on an article as well for the supplement talking about the role and really thinking about the impact of COVID-19. And I think there's data of showing, of course, delay in screening, delay in diagnosis, and what that impact is. But Sharon, I'd like to ask you, as the author and one of the leading authors of that article, and really just thinking about care delivery and being really close to that work, the impact of COVID-19 has been significant. Can you describe the role of patient navigation? What role navigators played in that time? What are some of the challenges, myths, and misconceptions about navigators that we might have had? And then even just a word about how we're going to be moving forward, I think, with the pandemic. And Sharon, we'll have you close out today. But Sharon, I'm going to punt to you.
Thank you, Andy. And I love that patient navigator voice, and it was critically captured here. To our knowledge, this study is the first accountability of the working changes to the sample of the cancer navigation workforce in the United States during the early phases of COVID. We looked at two phases. We called phase 1, which was March to May. And if you can think back, even though we're kind of going forward now, doing well, what we all faced from March to May in 2020. And then the second phase was from June to September in 2020. But more than 3/4 of the navigators reported acquiring new COVID duties during phase 1 and phase 2 time periods. By the second phase, the expectation of returning to the patient navigator's duties and original hours had lengthened a little bit. So what navigators were showing was they were very flexible. A lot of them got pulled out to do a lot of the COVID screening that was required at that time to get into our institutions. But to me, that was a compliment, because it left the nurses and the other navigators that were doing other things, such as the financial needs of the patients, were still being addressed. The clinic nurses were still able to give chemotherapy, the radiation nurses giving the radiation, inpatients stay where they are. This group showed that they had role flexibility during that time. Similarly, by phase 2, the delays and cancelizations observed during the patient navigators patients decrease. But as getting the people back into the healthcare system decreased, their basic needs and their worries increased during this time. We did continue to see the screening delays, which we're continuing to work with today. But the workforce identified a range of major concerns and needs among their patient groups, including financial issues, food. They quickly realized the mental health concerns that were going on and the social isolation. And we do capture stories of actually in the food deserts, or even if you think of the elderly that were afraid to go out and get food, the navigators were actually taking upon themselves finding funds, soliciting people around them, saying, we need some money to go get Mr. Smith or Miss Jones some food. They were delivering food to these patients. It was that basic needs that they were looking at this time. And I love the responses to the opening questions that we put. They actually said they identified a need for ongoing training to understand the new information and the recommendations about COVID-19, because patient navigators were often required to tackle that COVID-19 misinformation and the myths. And it was interesting to hear some of their comments that they shared with us. Now, let's think back to early 2020, and this is what they were hearing. If you put on a mask, you will suffocate and die. You can get it in foods. You can get it from your pets. Then as it went on, of course, we always heard this is a hoax. It's just like a cold. But then they got on to talking about how they could treat it. They told us that they could drink hot ginger tea and they wouldn't get it, or they could eat things like garlic and onion and spices and they wouldn't get it. Then it got down to almost, okay, we're tired of this. And there was a little bit of anger that came out in the patients where they felt like that people were getting it just so the hospitals and their doctors could make money. So your navigators were trusted individuals on the front line who actually addressed a lot of these myths. It showed that the navigators quickly adapted to the evolving needs, whether it was screening, testing, patient education, addressing the interruption of patient care. And we saw that they can be trained navigators in the future. Takeaway is, let's get ready for the next crisis that's going to hit. How can we quickly convert these people to be trained to meet whatever the needs are of the patients at that time? We do know that they're very versatile and that they advocate for this undervalued labor force. That navigators play a key role in addressing the needs of these under-resourced and the vulnerable communities, but the communities identify them as a place to get access to care and as a place to get access to their questions. I love one of the navigators that said, we are the community voice of what is happening, and the patients reach out to us to explain the why behind the safeguards and to address the rumors of no care, no facility access, and treatment for the only select age groups. So both the clinical and the non-clinical navigators showed that they had the potential to engage in coordinated care on behalf of the patient. So they balanced the clinical needs and the needs just obtaining practical support and financial assistance all along. So it was really exciting. And another thing that this profession shined at during this time, they recognized their own needs. They recognize their own risk at this point of possibly self-care and self-reduction strategies that they need that would carry on. So all I can say is we are going to learn from their voices. We're going to take it forward, and we're going to be prepared for the next crisis around the corner.
Sharon, I think that was beautiful. And I think it wraps this up, because I think one of the questions we didn't get today is, what is the key about patient navigation that makes it really so magical? And what is it? It's not a gene therapy. It's not a bright new technology. It's not a pill. But I think what you just shared is that it's really the people who are at the front line looking at the critical needs, versatility, thinking about what's next, and a true connector to the resources and services that people need. And I think you exemplified that beautifully. So I just want to say, on behalf of the National Navigation Roundtable, a huge thank you to the journal Cancer for the supplement. I would encourage all of you to explore the supplement, really think about how to apply the information and discussion from today. You know, a journal and articles are only as good as they are applied in terms of looking at the sustainability, really furthering navigation, and really making sure patients are at the center of our work moving forward. I'd like to thank all of our panelists for joining today, all the support from Jasmine, Michelle, many of the folks who are working behind the scenes to really make today happen. Thank you so much. We will have an ongoing series through the NNRT about the supplement, about the work, the applicability, and how we're going to use this information to really help support navigators for fair, equitable wages, for delivering patient-centric work moving forward, and to really just decrease cancer disparities moving ahead. Thank you so much for joining everybody today. I just have to tell you, it's my first day back from maternity leave, and this was a really good way to kick things off. So I hopefully will show up next time with a little more sleep, but I couldn't think of a better way to come back to work. So thank you so much. Enjoy your afternoon, and please delve into our supplement. Reach out to the NNRT for membership, and we'd love to continue to work with all of you. And thank you to the Journal Cancer again for really making today very lively, interactive, and the journal supplement come to life. Have a great day, everyone.
Thank you for joining us today on Cancer Speak. We hope you've enjoyed this special series on patient navigation and gained some valuable insights and a deeper understanding of this critical intervention for improving care across the cancer continuum. This episode of Cancer Speak is brought to you by the American Cancer Society Journal's editorial team. Be sure to follow Cancer on Twitter and follow the American Cancer Society Journals on LinkedIn. If you haven't already, be sure to subscribe to Cancer Speak so you never miss an episode, and please share this podcast with others who also might find it valuable. Until next time, this is Cancer Speak, the podcast of the journal Cancer, signing off.